So coagulation. So once upon a time, right, when humans were mortals, don't mind me. So we have three systems, right, for dealing with blood loss. And I want you guys to make this like super clear, clarify them in your mind, put them, in three categories, three things that we need or components that play a role in forming cloth. We have the vessels. So vessels help form cloth. That's super important. And then we have platelets, and then we have coagulation factors. So three components for coagulation: blood vessels, then platelets, and coagulation factors. You can think of each component as separate as well as connected, right? Right. Components are kind of separate. They operate on their own, but also they work together, right, at the same time. So we're gonna see maybe each of them separately and then talk about how they are connected. So you're gonna see the link right between them as well. And we're gonna talk about different tests that you can use under each category to determine what is wrong or localize it to which component is causing bleeding, and then also look at maybe examples of conditions that can affect each one and how that will present just quickly. So what roles do blood vessels play in clot formation? First of all, if a patient suffers an injury right now and they're bleeding, there's this transient neurogenic vasoconstriction, right? Neurogenic vasoconstriction. And for some reason, they like testing these. Yeah, sometimes. So if patient suffers a cut, the bleeding, the vessels will respond first. They're trying to slow the bleed, and they cause this neurogenic, right, vasoconstriction. So the vessels with the smooth muscle will contract like momentarily. It's so transient, like within seconds. It doesn't last that much. Yeah. So just to slow down the bleed. So once this stops, the next thing the next role the vessel plays that what the vessels they have the endothelial cell now. So remember this is the muscle. The vessel constriction is going to be the smooth muscle, right? Now the endothelial cells become super important. So what happens is endothelial cells they release things, right? They have endocrine function. They can release neuropeptides, hormones, things like that. And those neuropeptides and hormones they create like a balance, right? We have two major categories of hormones made by endothelial cells, as well as maybe some other cells like platelets as well that will play a role also in clot formation. We have pro-thrombotic, right, factors, and we have anti-thrombotic factors. So factors that will promote clot formation, factors that will inhibit clot formation. An example of prothrombotic is thromboxane A2. So thromboxane, right? Thromboxane A2 would be an example of a pro, right? Thrombotic factor. It actually activates platelet, right? It's procoagulant. So endothelial cells can also make this guy. And that's what endothelial cells is going to do what they're going to release what vasoconstrictive peptides, right? They're going to release peptides that will actually constrict the vessels a little bit and slow down blood flow, and that will also decrease blood loss and help platelets, right, aggregate better and form a plug to block the hole. So they may release some sort of like what's the endothelin, right? Endothelin is a vasoconstrictor that will help kind of slow down blood flow. So it's also prothrombotic in that fact, in that sense. Antithrombotic will be a lot of like nitric oxide is a vasodilator. It's gonna blood will be flowing too fast, platelets cannot aggregate, right? Yeah, very well. Also things like serotonin. Serotonin is actually pro-thrombotic, actually, not anti-thrombotic, because serotonin can activate, right? Serotonin can activate platelets. So we can put serotonin here. So nitric oxide will be antithrombotic. Prostaglandin I2 will be antithrombotic, right? Prostaglandin I2 will be antithrombotic. Uh, right, I think those are the major ones. There's another factor called platelet activating factor, PAF, definitely prothrombotic, right? So there is normally, if there's no injury to the blood vessel, there's a balance between, right, these prothrombotic and antithrombotic factors. So I'm not forming clots at homeostasis. But if there is a trauma, there's a trigger, blood vessels are ruptured, endothelial cells get activated, and they're going to be making more prothrombotic than antithrombotic, right, to promote clot formation. If there's something, a pathology affecting those prothrombotic, for some reason they are not elevated. Maybe patient is taking NSAIDs, right? Not thromboxane A2. Patient is taking endothelin receptor blockers, right? It might be difficult for that patient to form clot because there will be more antithrombotic, right, than prothrombotic. Or if there's a disruption where there's actually more prostaglandin I2, there's a lot of nitric oxide, right, in the blood vessels or wall of the blood vessels, that may also inhibit clot formation because those factors are antithrombotic, right? Yeah. So, right. If you remember Vehicles triad, right, where a patient, basically the principle and pathogenesis of DVT, right, or clot formation in the veins, right. We have the endothelial injury, we have the hypercoagulating state, right, and we have venostasis. That is endothelial activation, right, has to do with these factors. If the endothelium are activated or they get injured somewhere, there will be prothrombotic factors will be higher than antithrombotic, and that promotes, right, cross formations like DVD. May also play a role in even arterial thrombus, yeah. And we may also need them to form normal clot, right, if blood vessels are ruptured. So you can see blood vessels super important. So this level too can be tested. It may cause imbalance at this level, may lead to, right, procoagulable state where patient will be forming clot a lot like DVT and stuff like that. So the examiner can test this as well. Keep that in mind. And even conditions like pulmonary hypertension, right? Like idiopathic pulmonary hypertension, they may have a lot of prothrombotic factors, a lot of vasoconstrictors, right? Endothelin, thromboxane A2 will be higher, and like nitric oxide, prostaglandin I2, and that will lead to vasoconstriction. They may lead to clot formation in the pulmonary vessels. Eventually, the pressure goes up. Yeah, that will come to pulmonary hypertension. So this level to a lot of things can get tested at this level. Then the third thing, right? That the third component of the vessel that will contribute to clot formation is what? Is the subendothelial collagen. Right. So vessel ruptures will damage the endothelial cells. What are you exposing? What is below the endothelial cells? Collagen. Right. So what role does collagen play? Collagen is linked now to what? To platelets. This is the connection between vessels and platelets. So endothelial collagen is linked to platelets. So what is the link between submental collagen and platelets? Submental collagen will bind to what? To von Willebrand factor, right? And then von Willebrand factor will bind to GP1. Is it GP1A or GP1B? GP1B, right? Receptor on platelets. And this mediates what? Platelet adhesion. So it allows platelets adhere. Platelet adhesion. Right? This mediates the first step in platelet function, which will be platelet adhesion. Right. So where do we start? There's an injury, vessels respond first, right? Transient neurogenic vasoconstriction, the smooth muscles, transient. Endothelial cells, they make all these prothrombotic factors and thrombotic factors. We're going to see some of them later on when we look at platelet function, like thromboxane A2, platelet activating factor. So their goal is to, okay, help constrict the vessels, slow down blood flow, right, which is slow down blood loss, and then also activate, right, yeah, interaction between the vessel wall and platelets. May also play a role in coagulation factor, right, activation as well, just to form that clot, that plug, to plug the hole, right, the bleeding. Then, if endothelial cells are damaged, below the endothelial cells, subendothelial collagen will be directly exposed to the blood. Subventricular collagen, which is normally covered, right, by endothelial cells, will be directly exposed to the blood. And what will that do? Collagen will interact with von Willebrand factor. Von Willebrand factor, which is also released by endothelial cells, by the way, right? Remember, endothelial cells actually have what they have. They have von Willebrand factor and they have factor 8, coagulation factor 8 in the what, in the wobble Palladi bodies, right? Yeah, wobble Palladi bodies. Yeah. So von factor, which is also released by endothelial cells, activating endothelial cells, will bind to subventricular collagen and then connect the collagen to the what, to the platelets, GP1B receptor on platelets, which will mediate the first step in platelet activation or function, which will be what, platelet adhesion. Allows platelet adhere, right, to the subventricular collagen so that they can form the hole, right, to plug the problem. Guys, so far so good? So far so good?
Yes, sir.
Okay. All right. What can affect subventricular collagen? I mean, this will not surprise you, right? Why patients with vitamin C deficiency will bleed? Because yeah, here we are. We need the collagen in the white blood vessels to actually stop bleeding, to stop to form clots. So if a patient has weak subendothelial collagen, so dealing with conditions like vitamin C deficiency, I think copper deficiency as well. So now the examiner can take you back to biochemistry, right? Remember, vitamin C is the cofactor for what? For hydroxylase, right? Enzyme, right? Proline and lysine hydroxylase. Copper is the cofactor for lysine oxidase enzyme, right? And we need these enzymes to make the super strong, right, triple helix, right, of collagen. So if those vitamins are deficient or copper is deficient, collagen is going to be super weak. Yeah. And right, they can bleed easily. Even look at conditions like Ehlers-Danlos syndrome, where there's a mutation in collagen itself, EDS, they can bleed easily. You can also play with like bleeding disorders. The wall of the vessels are not that weak, strong. So if collagen is not strong, it cannot form it cannot allow platelet, right, or foster platelet adhesion. So it's going to be difficult to form clot in those patients, and that's why they can present with bleeding ECs, right, bleeding gums, etc., right, hematrosis, so on and so forth, right? So that is where collagen comes in. All right, now let's move on to platelets. So platelet adhesion, you can see what we need, right, for platelet adhesion. This is what we need. We need subventricular collagen, membrane factor, and GP1B receptor on platelets. So we're trying to group. Now, how will I test, right? How will you test platelet adhesion? There's a test for platelet adhesion, right? Anybody knows the test? How do you test platelet adhesion? You can test this in the lab. So we test this with what? With restositin test. Restositin test, right? Is testing platelet adhesion. That's all it's testing. Membrane factor, GP1B receptor. Maybe collagen as well, yeah. But that's what restositin test in the lab. So you can see this test is about platelets, primarily. Restositin test. So if I give you a vignette, patient has some bleeding disorder or problem, and they give you the restositin test and it's abnormal, right? Automatically you've narrowed down the pathology to what? Two things or maybe three things if you want to be comprehensive. GP1B, membrane factor, likely collagen, cellular collagen, but definitely membrane factor and GP1B receptor on platelets. So that test we should know. Then if you go down, so platelets they've adhere, right, to the endothelial collagen. What is the next thing that platelets will undergo? They undergo what? Activation. Platelet activation. Right. And platelets activated basically through the P2Y12 receptor. P2Y12 receptor, which is adenosine receptor. So one of the factors that will activate platelets is adenosine. Right. This P2Y12 receptor actually binds to adenosine to activate platelets. Also, we already mentioned serotonin as well. Serotonin can activate platelets. yeah, as well. And this receptor is actually what? It's an alpha, it's a GI, it's alpha 2 receptor, which is G inhibitor, right? So which means increasing, if you activate decreasing cyclic AMP, decreasing, right? Cyclic AMP in platelets actually activate platelets. If I decrease cyclic AMP, it activates platelets. If you increase cyclic AMP in platelets, that inhibits platelets. They're not going to work properly. It's going to inactivate them. Yeah. But the point of this activation is that what is platelets will express, right? So P2 receptors are activated by adenosine, which can also be made, right, by endothelial cells, by the way. Right, so we can put that here as well. Prothrombotic, another one will be adenosine here. Right, so and adenosine activates P2Y2 receptor on platelets, which will activate platelets. The purpose of activating platelets is what? Is for platelets to express GP2B3A receptor on their membrane. Right, so activation leads to expression of GP2B3A receptor, which we need for what? Platelet aggregation. So platelets adhere to the collagen, they become activated. So once they become activated, the granules, they're going to degranulate, release their granules, release serotonin, release adenosine from their granules and some platelet activating factor, maybe some coagulation factor as well, release calcium from their granules, and then also express on their membrane, right? The using actin and microtubules, they're going to express GP2B3A receptor on their membrane, and that is needed for what? Platelet aggregation, right? Yeah, GP2B3A receptor. It's going to be needed for platelet aggregation. Allows platelets to come together, right, and form bonds so that we can form a very, very large clot, right? How do platelets aggregate? So this is where coagulation factor comes in. This is the link between platelets and coagulation factors, coagulation cascade. The link between that is what is fibrinogen. So for platelets to better aggregate, so let's say this is a platelet molecule here. This is platelets here. Platelets is they're expressing what? They're expressing the GP, right? 2B. This is a platelet molecule expressing GP. Remember our last column is coagulation factors. So I don't want to draw platelet there. I'm going to draw platelet on this end. So this is the GP 2B3A on platelet. This is another platelet molecule here, another platelet cell, also expressing its GP, right? 2B3A receptor. So for proper aggregation, it's like think of platelets like bricks, right? Bricks, the building blocks of bricks for building If I stack a bricks together, right? You stack bricks on top of each other without anything else. You just stack them up. That's not it's not going to provide enough strength, right? Those bricks will fall apart easily. The wall can fall apart easily. It's not going to be strong. But if I stack up bricks and I put what? Plaster between them, right? Or cement between the bricks to hold them together more tightly, that forms what? A better, stronger bond. So if there's injury to the blood vessels, the initial plug we make, which is platelet plug, is not that strong. It is not very, very strong. It's like just stacking bricks on top of each other without any plaster in between or without any cement. It's not going to be very, very strong. It can get easily dislodged by just having blood pressure, high blood pressure, right? So we need to find a way, we need to figure out a way, right, to make the bricks stronger. The stacks of bricks, the stacks of platelets or aggregate, we need to reinforce the aggregation, make it stronger, form a stronger plug. So after that initial primary hemostasis, we need to do a secondary reinforcement. How do we do that? That's where fibrin comes in. So normally fibrinogen can do what? Fibrinogen can interact with this receptor. So you can see fibrinogen is like an inactive glue initially, inactive cement It's not dry yet. It's like wet cement, still weak, not dry yet. So fibrinogen is going to be between the platelets. It's going to hold the GP2B3A receptor together, right? Between platelets. But it's not strong. It's weak. It's ogene, inactive. So what do we need to do to this fibrinogen? We need to convert it to fibrin, dry plaster or cement, stronger to hold the platelets together and form a stronger platelet plug. Right. So, and how do you convert fibrinogen? We need coagulation factors to do that. It's a coagulation factor, but we need other factors to activate fibrinogen. So that's why you now move on to your coagulation cascade. That's where that comes in. But before I go to that cascade, right, let's talk a little bit about, let's finalize some things about platelets. What test can I do to determine the function of platelets? So there are two things you can do. There are two tests we usually do, right, to kind of see if we have enough platelets or if they are working well. There is the quantitative test. There's a test to check the number of platelets we have. Quantity, right? There are tests we can do, right? Quantitative platelet test. And this is where your CBC comes in, right? Platelet count. So platelet count tells me about quantity. Do I have enough platelets? Then tests like what? Resuscitation test. Resuscitation test, which tells me about adhesion, tells me about function, quality, but specifically about adhesion. And you also have other tests like what? Platelet assay. Platelet assay, as well as tests like bleeding time. Platelet assay or bleeding time, which also tells me about what? Quality, right? Quality or function. But bleeding time tells me about all the function of platelets. Adhesion, activation, aggregation. Resuscitation test tells me about function, but only about adhesion, specific. Count tells me about quantity, right? So if a patient is, so which means if I give you somebody with a bleeding disorder, patient is bleeding. These are the tests to tell me if the problem is due to platelet issue or not. Am I dealing with platelet issue or I'm dealing with something else? So the patient has a bleeding disorder and you check platelet count is low. Right, now you're dealing, okay, it's likely platelet. Quantitative platelet disorder. Something's wrong with platelet count. So I'm dealing with disorders that will decrease platelet number in the blood, disorders that will destroy platelets, thrombocytopenias, disorders that will decrease platelet production in the bone marrow. Those are the things I'm thinking about. Oh, a patient has bleeding disorder, platelet count is normal. So you think, okay, yeah, it's not a quantitative issue, but bleeding time is increased. It takes them a longer time to form clots. Bleeding time is increased. You know for sure it's a quantity, it's a quality issue, quality, functional issue. It's not a quantity issue, it's a function. So I have normal platelet count, but they are not working well. So now my mind will go into something affecting what? Oh, platelet adhesion. Ah, maybe it's GP1B receptor issue. Or maybe it's bone factor, right? Issue. Oh, something affecting platelet activation. Oh, maybe it's P2Y12 receptor. Maybe something's wrong with adenosine receptor. Something's blocking the receptors like antiplatelet or drugs that can block that. Oh, maybe it's aggregation issue. Or something's affecting thromboxane A2, which I need for aggregation. Something's affecting GP2B, 3A receptor, right? Yeah, bleeding. If the examiner wants me to narrow it down further to either adhesion or one of those three functions, they can give me resuscitation test. If the examiner also gives you resuscitation test now and that is abnormal, you know you narrow it down to what adhesion issue. The problem with adhesion, you narrow down your answer better. If the examiner doesn't give me or gives me resuscitation test and is normal, patient has normal platelet count, bleeding time is increased, you know, it's a functional issue, but resuscitation test is normal, then that rules out adhesion as the cause. You're focusing on either it's an activation issue or it's what aggregation, right? Issue at that point, yeah. But that's how you interpret these labs to kind of quickly narrow down where the problem is. So these tests do not tell me anything about coagulation factor. They are telling me about platelet itself. So if they are abnormal, your answer has to be platelet related, something that can affect platelets. with or without coagulation factor, right, effects. Yeah. If these tests are normal, platelet count is normal, resuscitation is normal, bleeding time is normal, go and rule out every option that has to do with platelets in the option in the list, and then you focus on another thing. Maybe it's a vascular issue, blood vessel issue, or coagulation factor issue. Yeah. But this is how you up. So they are separate but still connected somehow. Yeah. All right. So now let's transition to coagulation factor. So we know now the connection between coagulation factor and platelets, right, is fibrinogen. We need fibrin for beta to reinforce platelet aggregation. So how do we activate fibrinogen into fibrin? Because fibrinogen is not like inactive glue. We need to convert it to fibrin, which is stronger, forms stronger bonds, right, between the platelets and reinforce the cloth and prevent, right, bleeding. So what we do is we have two things. We have two pathways to get to fibrin, to go from fibrinogen, right, to fibrin. So the first pathway is what the extrinsic, right, extrinsic pathway, and extrinsic pathway, and then we have the second pathway called intrinsic pathway, and both of them they meet somewhere in the middle, which we call the common pathway, right? So extrinsic pathway starts with what, factor 7, right? Actually starts with tissue factor. So once endothelial cells are damaged, right? So you can see so many things coming from endothelial cells. These guys are super important, right? Another pro-thrombotic factor here will be tissue factor, also made by coagulation factors and by endothelial cells. So once endothelial cells are damaged, they release what, tissue factor. Tissue factor. So once they release tissue factor here, tissue factor will activate factor 7. So tissue factor converts 7 to 7A. Right, because all the coagulation factors are inactive, which makes sense. They are going to be inactive in the blood until we need them. So we're going to activate them, right? Yeah. So 7 becomes 7A. And these coagulation factors, they are proteases, right? They are proteases. They are enzymes that can cleave proteins. Right, it's like ACE inhibitor, ACE enzyme, right? Angiotensin converting enzyme converts it's like renin. Renin converts angiotensinogen to angiotensin 1. Angiotensin O gene is inactive. O gene is inactive part. You remove that, you have angiotensin 1. These factors too, like fibrinogen is inactive, you remove the O gene, you have fibrin. All of them to 7 has the inactive part, the zymogen, and then you cleave that or you convert it to, right, active 7, then the 7A, which is a protease, can cleave the next factor, convert it to the active one, right, and so on and so forth. So 7A will convert what? So it's going to take factor 10, inactive factor 10, and convert it to what? Factor 10A, active 10A, and then 10A together with factor 5 will activate, factor 5A will activate factor 2, convert 2 to 2A, right, which is thrombin, and then 2A will convert fibrinogen. Here we are, right, 1A it's gonna so it's gonna convert fibrinogen inactive 1. It's gonna convert 1 to 1A, right, which will now form this very nice fibrin, right, active fibrin, and it's gonna form a mesh, strong glue that will hold, right, the platelets together and reinforce platelet cloth or aggregation. Yeah. So here, and then I have the intrinsic pathway. Intrinsic pathway is gonna be affected by things like glass, like or foreign body in the blood. Glass, foreign body in the blood can activate the intrinsic, and or even fibrinogen can go the way fibrin, activated fibrin and thrombin, they can go and activate intrinsic pathway as well. Yeah. So we have 12 here, 12 to 12A, then 12A converts 11 to 11A. 11A converts 9 to 9A, and then 9A together with 8A. 9A factors 9 together with factor 8, activated factor 8, will convert 10 as well to activated factor 10. Yeah. So 12, 11, 9, 8, 10, 5, 2, 1. 7, 10, 5, 2, 1. Right. So that is the common pathway. Guys, give me a moment, okay? Right back. Okay. Right. So these we have to know this, right? Unfortunately. But yeah, you have to know these factors, know the intrinsic pathway, know the extrinsic pathway. So we have no choice because it's you can see why it's super important. You can use that to look. You need to localize what patient has a bleeding disorder and you know is due to coagulation factor defects, right? You need to be able to localize it to which factor or which pathway, right, the defect is. So it's going to be super important. So to keep it simple, 7, 10, 2, 1, 5 is a cofactor, and then 12, 11, 9, 10, 8 is a cofactor. Right. So this here is the common pathway, right? Common pathway, which means if anything happens to the factors in the common pathway, right, both intrinsic and extrinsic will be affected. Yeah. But then we know 7 is only confined, right, to extrinsic. It's specific for extrinsic pathway. And then these ones, 12, 11, 9, 8, they are specific to what? The intrinsic pathway. So how can I test these pathways? How can I test these factors and their function? Here, if I want to go from 7 to 1, if I want to test how long, right? How long it will take to go from factor 7 to fibrin, that's going to be what? PT, right? The time it will take to go from 7 to fibrin, that will be PT. This is approximately 15 seconds, right? And we also call it another equivalent test to PT will be INR, which is typically between I think 1 to 2. And for the if I want to test how long it takes in the lab, right? After factor 12, I want to test how long it takes to go from 12 to 1. That would be what? PTT, right? PTT, which is going to be longer, definitely. So it's about twice PT. So if PT is 15, PTT is approximately 30 seconds, right? Yeah, twice PT. So this is how the examiner will tell you what is going on. And you can see that these are specific to these, right? These are specific to this pathway. Like PTPTC, they are specific tests for coagulation cascade, not platelet and not vessel wall. It is the coagulation factors. So if patient is bleeding, PTPTT INR normal. I mean, I don't care. My answer will not be a coagulation cascade answer. It's not going to be a factor answer. It has to be something else. Maybe a platelet issue or it's a vessel right issue. Yeah. Patient is bleeding. Something's wrong with PTPTT. Then you know your answer will be somewhere here or related to these cascade somehow. Yeah. So you have, that's how you narrow it down, right? Between those three, right, components that we talked about. PTBT talks about this. If you want to narrow it down further to which factor, the examiner can also test, right? They can test that. They can give you scenarios where maybe one of the time is increased, the other one is normal, right? And it's gonna make a lot of sense, right? So let's see. Factor that is deficient, factor deficiency, PT, INR, PTT. And then you can also, there's also a test called TT, right? Thrombin time, which is basically from here. Thrombin time is looking at how long it takes to go from 2 to 1, right? Right. Thrombin time, the time looks at how long it takes to go from factor 2 to 1. That'll be TT, right? So you can also see that. So let's say a patient has deficiency of factor 7 only. Only factor 7 is deficient or affected. I mean, since it's common to only, right? It's specific to only the PT or INR, right? Only the extrinsic. So you can see, I can pretty predict that this will definitely be increased. What happens to PTT? Normal. TT will be normal. If it's just factor 7 that is deficient, only PT, INR will be affected. If a patient has problem with factors 12, 11, 9, or 8, like hemophilia A and B, right? We can affect 9, 8. Yeah. So that is that would be what that would PTI now will be normal, PTT will be increased, TT will be what? Normal. You can see, right? These guys are only specific to the intrinsic, so only PTT will be affected. The other third time should be normal. That narrows down, right, to those factors. Or if a patient has problem with the common pathway, 10, 5, 2, or 1 is deficient. Maybe somebody is taking direct factor 2 inhibitor, direct thrombin inhibitors. They have factor 10, right? Inhibitors. They're taking direct factor 10 inhibitors. What happens to these tests? All right, because these are common factors. All the times will be increased, 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 right? Yeah, for sure. But now, yes, TT will vary, right? TT will increase if 2 and 1, 2 or 1, right, is deficient. Right. But TT will be normal if it's just 10 or 5 that is deficient, which makes sense. So imagine if it's 10, 5 that is deficient, right? They are both TT. So PTT, PT will be increased, but TT will be spared. But if it's inverse factor 2, 1, for sure, all the time will be increased. PTT, PT, TT as well will be increased. Right? Von Willebrand factor is connected, right, to this axis we are here. Willebrand factor is connected here to factor 8. Willebrand factor actually protects factor 8. So another thing that links, so you can see there are two things that links platelet with coagulation cascade so far. The first thing is the fibrinogen. Yeah, aggregation, platelet aggregation. The second link between platelets and coagulation cascade is what is von Willebrand factor, right? Von Willebrand factor. So in patients with von Willebrand disease, they have what? Platelet issue, problem with platelet adhesion. They also have what? Increased PTT because factor 8 will be deficient as well in those patients. Yeah, making it probably the only disorder, right, that affects both of them. Well, that affect the only platelet disorder that can also affect, primary platelet disorder that can also affect coagulation factor or PTT, von Willebrand disease. Although DIC can affect both as well, some other things like that, but yeah, von Willebrand disease can affect both of them, PTT and bleeding time, resuscitation test, right, will be affected. But the platelet count will be normal, right? Yeah. So with these, yeah, we should know. Also know that there's a way to regulate this pathway, right? How do we regulate this pathway? We have antithrombotic, right? Like antithrombin 3. Interleukin 3 can inhibit factor 10 and factor 2, right? We also have protein CS. Protein CS complex can inhibit factor 3 and factor 5. They can inhibit the cofactors. Yeah, 8 and 5 rather. 8 and 5. Yeah. Antithrombin 3 can inhibit 10 and 2. Yeah. So this keeps the factors in line. Make sure there's homeostasis, right? We don't want excess clot formation. We want it balanced. Yeah. So if there's too much coagulation factor than anticoagulant, right, that can lead to clot formation, right? Hypercoagulating state, which will lead to DVT. So the second mechanism in vehicles, right? Triad. Yeah. So if there's a lot of coagulation factors more than anticoagulant, clot formation. If there's too much anticoagulant more than coagulation factor, bleeding, right, will ensue. Yeah, they can form fibrin, so it doesn't reinforce the platelet. And also, I can break down over time. I can start breaking down the fibrin, right? So once I form enough fibrin, I can break it down, right, to fibrin split product or fibrin degradation product. Yeah, as well as things like D dimers, and this will be done by what? By plasmin, and plasmin 2 is in the inactive form, plasminogen, and going back to TPA, right? Which is also made by, so TPA, which is made by platelet coagulation factors as well as by endothelial cells. TPA will be antithrombotic. Tissue plasminogen activator is also made by endothelial cells, so it's going to be antithrombotic. It's going to break down fibrin into degradable product or degradation product, and it can, that's why clots will resolve over time, right? Once the bleeding stops initially, clots can get degraded over time and its resolution. Yeah, and the area will heal, blood vessels will heal back, things like that. So these two we should know. If there's a problem with, if there's too much plasma activity, I mean patient will be bleeding, right? They cannot form effective clots. Yeah, if there's too little fibrin, it may also lead to maybe hypercoagulable state as well, because they can be forming too much fibrin and problem, right? So there's always a balance with these whole axes. But my point here is there's a clear-cut difference between all of them. So three components clearly different. They have their own different separate function. However, they also what? Interlinked somehow. So your first goal to make your life easy is problem with any of them can lead to bleeding. So that doesn't help me, right? Doesn't help you. What helps you is what? What is specific? What test narrows down the pathology, right? To which component? Patient has bleeding disorder, all my platelet test and PTT is normal. Right, definitely you're dealing with what? You're dealing with visceral issue. So let's do some summary here. Summary. Patient is bleeding doesn't, whatever bleeding patient has doesn't really help me much because all of them can cause some sort of bleeding, right? Although sometimes examiners will try to give you different bleeding patterns like maybe petechiae, ecchymosis, blah blah blah. There are some specific bleeding patterns that actually you need, like bleeding gums, maybe more for scurvy and things like that. But it's still not specific. I mean, bone marrow factor can have bleeding gums as well. It can have bleeding with tooth extraction. Yeah, platelet disorder can also have that. Yeah, so menorrhagia, maybe definitely platelets for sure, disorder, but even this can happen with, right, any other coagulation factor as well, or coagulation factor deficiency as well and stuff. So I'm saying those trends, they are suggestive but still not diagnostic. So your best bet would be what? Your objective findings and your labs, right? That's what you're gonna use. So if a patient has bleeding, so bleeding disorder, patient is bleeding, plus all tests are normal, all platelet tests and coagulation factor tests, PT, PTT, INR, TT normal, then you know that what the problem is, what? The vessel. The problem is somewhere with the blood vessel. That's where the problem is, likely subventricular collagen. So you're thinking scurvy, right? Copper deficiency, maybe elastanolos, right? Something is wrong with the vessel. It's the vascular issue. It's not platelets, not coagulation factors. Yeah. If a patient is bleeding and the patient has low platelet counts, right? I mean, and if platelet count is low, you know for sure, right? Bleeding time will be low as well. Because, right, that's the thing. If something's wrong with the number of platelets, they won't work properly either. So my bleeding time will be increased. Bleeding time, BT will be increased. Yeah, as well. Definitely, you're dealing with what? A quantitative platelet disorder. Right, quantitative platelet disorders, that's what you're dealing with. So now you can further, you're thinking either increased destruction. So I'm going to be picking something related to thrombocytopenia, increased destruction of red blood cells or platelets, maybe ITP, HIT, TTP, that, all the P's, right? No, actually, just platelets only. TTP is, yeah, TTP, right? TTP, ITP, yeah, HUS, yeah, HIT, all those are like specific, right? Platelet destruction problem. Yeah, that targeting platelets. And then so increased destruction or it may be decreased production. So bone marrow issue, right? Bone marrow, bone marrow issue, bone marrow issue, decreased production. And that case you might see maybe pancytopenia as well. Not only platelet is low, every other cell count is low in the blood. So you think okay, likely bone marrow issue is a production issue and which can be leukemias and co, right? Can do that. And then there's something called pseudo false hyponatremia, right? So where there's clumping, so on peripheral blood smear, you're gonna see clumping of platelets. That can also cause thrombocytopenia. Yeah, so for it's pseudo thrombocytopenia, platelets are just clumped together in the on peripheral blood smear on the slide. So it appears that the count is low, but actually it's not. So that's something else to keep in mind. Right. So that's what I'm thinking about. If a patient has bleeding disorder, patient is bleeding, and they told me that platelet count is normal. So now you're thinking, oh yeah, it's not a quantity issue, right? Platelet count is normal, but is it a platelet issue? Oh, it is a platelet issue, but bleeding time is increased. Now I know it's a functional, qualitative or functional platelet disorder. Platelet issue. Quality of function is not quantity. So all the thrombocytopenias, production issue, throw them out of the window, right? And then you're focusing on okay, aggregation issue, right? What can affect adhesion? Okay, von Willebrand disease can affect adhesion. GP1B deficiency. Isn't this one we call what's the name? Bernard Solier, right? Bernard Solier, right? So von Willebrand disease, GP1B deficiency. I'm thinking that, right? And to confirm this, the examiner can give you what? They can also give you resuscitation test. So if it is the addition, resuscitation test 2 will be what? Will be abnormal. Yeah. If resuscitation is normal, then I'm dealing with right aggregation. It may be aggregation issue, GP2B3A receptor, or it may be what? It may be activation issue. Maybe something is wrong with P2Y12 receptor. For some reason, the patient has increased cyclic AMP in the cytoplasm, right? Yeah, all these things will affect platelet function. So the count to be normal, function, bleeding time is increased. The such test is abnormal, you know is adhesion. If they give you that and it's normal, then you rule out adhesion issue, focus on aggregation or activation, right? Issue in that patient. So bleeding, that. If a patient has bleeding, patient is bleeding for fourth scenario plus increased PT or INR plus normal so plus increased PT INR plus or minus increased PTT as well as maybe TT as well. I mean all this definitely you know you can, and actually the examiner also tells you that what right we have normal platelet count, there's normal bleeding time, right? That tells you the platelet is not the issue at all. The issue is definitely coagulation factors. Yeah, then your answer related to the word coagulation cascade. and you can use which test is abnormal, right? And narrow it down to which factor, right, we're dealing with in that case. And then if a patient the patient is bleeding, but platelet count is normal, increased bleeding time, they also have increased PTT, but PT is normal, normal PT, normal TT, then this is going to be von Willebrand disease, right? Remember, von Willebrand disease will affect platelet function, adhesion, and affect what? Factor 8. But every other test will be normal. Von Willebrand disease. Then conditions that can affect both of them also will be conditions like, so sixth scenario will be bleeding, severe bleeding out of IV sites, orifices, etc. Patient has low platelet count, so it's a quantity issue. And if platelet count is low, bleeding time will be increased. Patient also has what? All the coagulation tests increase: PT, PTT, TT. Right. This is going to be likely DIC, right? DIC. DIC will activate, kind of use up all the platelets, destroy them, use up all the coagulation factors. So patient has low coagulation factors in the blood, and the test, right, for this cascade will be increased. Right. So those are going to be some scenarios, but it's all about interpretation, right? And you can see how easy it is. Create, compartmentalize the text, compartmentalize the components, know how they are linked, know which test is testing which compartment. And once you narrow down your answer, the likely percentage to a particular compartment based on the test that you're giving, you just go ahead and pick an answer in line with that compartment here, right? Or sometimes if you see evidence that there are more than one component involved, then you're picking an answer that you know it can affect multiple, right, components of coagulation. All right, guys. Any question on this?
Can you go back to number 6, please? I was finished
Oh, right.
checking.
Sorry about that. Okay. So number 6, everything is abnormal. Yeah.
Yes.
Number 6, everything is abnormal. Okay. Any questions?
Wait, can you go on one more time? I'm sorry.
Can I?
Please. I just missed one thing.
Where up?
No, can you scroll up?
Okay.
Yeah, right there. Thank
Yeah.
you.
Okay. All right. So today, try to do some questions. All right.
Doc, Dave, can
Yeah.
you finish with Victoria the second part of number 3?
Okay.
I think
Part of
activation.
three. Victor, are you done with this?
Yes, thank you.
Okay. Second part of number 3. Aggregation here for platelets, right?
No, when we're going through the summary, the
Okay, the
disorders.
summary. Okay, let's see.
Yes.
Right. So the summary for 3, bleeding plus normal platelet count plus increased bleeding time, right? And every other thing is normal. So quality functional platelet issue. First one is adhesion, problem with congruent factor GP1B. That will be confirmed by resuscitation test. And then aggregation GP2B3A receptor deficiency. That's the one we call Glanzmann thrombocytopenia. Yeah. And
The one you have the one with the one factor there. This is the GP
GP1B.
1B. Thank
Yeah.
you.
GP1B receptor.
Then you have adhesion. Oh, have aggregation.
All right, aggregation next, GP2B3A, and then you have activation, P2Y12, or anything like the cyclic EMP in the cytoplasm. Yeah.
Activation. P2Y12.
Yeah, P2Y12 receptor, adenosine receptor. Yeah.
An increase in cyclic EMP.
Right.
Thank you.
Okay. All right. Yeah. And all these components to pharmacology comes in play, right? So drugs we call antiplatelets, which are drugs that primarily target platelets. Yeah, they can work at any of these three steps of platelet function. They can act inhibit. We have drugs that inhibit platelet aggregation, right? That inhibit GP2, B3 receptors. We have drugs that will inhibit P2Y12 receptor and prevent platelet activation. We have NSAIDs like aspirin that will inhibit the thromboxane A2, right, synthesis, which also plays a role in platelet activation. So in platelet aggregation, actually, yeah, thromboxane, right, thromboxane A2 also plays a role here. Yeah, so NSAIDs can be there. So those are drugs that target primarily antiplatelets. And then for coagulation cascade, we also have drugs, right, that will target these. So we have direct factor inhibitors, right? Direct factor 10A inhibitors, 2A inhibitors. We have drugs that can activate antithrombin 3, right, like heparins. Yeah, we have drugs that will inhibit synthesis of some of the factors, vitamin K dependent factors, right? Warfarin, 27910 CS. We have drugs that will activate plasmin. So if the clot is already made, and I want to break down the clot very quickly, I can activate plasmin, right, by giving TPA, like outer place. Yeah. So the pharmacology to make sense, right? It goes in line with what we have, disrupting the normal physiology to prevent clot formation. Or if a patient is bleeding, I can replace those factors, right, to stop the bleeding. Yeah. Or reverse anticoagulant, warfarin with vitamin K, reverse heparin with protamine, etc. Yeah, or you replace the factors themselves. So you can build pharmacology on this principle as well. So important. Why do we need to? So here's my question though. So look at this. We know there's a link between platelets and coagulation factors, right? Why do I need to have antiplatelet and anticoagulant? Why not just inhibit fibrin? Like if I inhibit fibrin, platelets will not work very well anyway. Yeah, and if I inhibit platelets, for instance, right? Even if I form fibrin, there's nothing, no clot, no aggregation, right, of platelets. Clots will not be formed either properly. So why not just have one class of drugs to block just one component? And basically that should be enough to disrupt, right, clot formation. So why do we need to have anticoagulant as well as antiplatelets separately? And how do you choose between them? When do you know? How do you know when to use antiplatelet and when to use anticoagulant? How will you know which conditions will respond to antiplatelet, which ones will respond better to anticoagulants, right? Because we rarely use them together unless maybe emergency, but in terms of long-term treatment, we usually use them separately for different conditions. Yeah, and it's very important, right? Because that can allow you to understand the principle of choosing the medications. So it turns out, okay, we can form the clot separately, right? Although we have them connected like this, actually, sometimes a patient cannot form a fibrin clot without platelets activation. Sometimes patients might form preferentially, right, platelet clot or predominantly platelet clot with little or no increase from fibrin. Yeah, as other times they will be mostly just fibrin clots. Fibrin itself can be formed and also contribute to coagulation or clot formation with little or no input from platelets or without platelet activation. Yeah, so you can have scenarios where there is. So here's how you choose, right? Depends on the vessels where the clot is being formed, right? You can have different components of the clot. So if we're dealing with, let's say, clot formation, and this is pathologic, right? Pathologic clot formation is abnormal. This is not normal clot formation. Two types of vessels we have. We have arterial. So, and this is what we call thrombus, right? Thrombosis or thrombus formation, clot formation. There's arterial clots can form the arteries, arterial thrombosis, and there can be venous thrombosis. So that's how you divide clot initially, arterial and venous thrombosis. Remember our Vieco's triad. In the pathogenesis of clot formation, pathologic clot formation, when we're forming clots without like bleeding, a patient has, so we have, if the clot is from the arteries, right, out of the Vieco's triad, or let me put pathogenesis instead of Vieco's triad. Nobody will really test you on the triad directly. This is gonna be steps. So let's put pathogenesis here instead of saying Vieco's triad. Pathogenesis. The two there are two things we need, right? Two major things we need to form arterial thrombus. The first one, pathologic thrombus. The first one will be endothelial injury. Endothelial injury, out of those three principles, Vieco's triad, the two that are important for arterial thrombus formation will be endothelial injury. Actually, only endothelial injury. Only. That's the most important one. Only this one. Yeah, for this. For venous thrombus, it's gonna be the latter, the other two, which is stasis, venous stasis, and hypercoagulating state. And you can see that the word hypercoagulable actually corresponds to what coagulation cascade, not platelet. This word hypercoagulable, when we see this state, we're not really talking about platelets per se, although platelets may contribute somehow, but it's always almost has to do with coagulation factor, having of hyperactivity of coagulation factors, or having less anticoagulant like antitrophin 3, things like that function here. So stasis, hypercoagulable state. Arterial thrombus, endothelial injury is the major one. Now, let me ask you guys this. If we damage endothelial cells, right, what are we exposing beneath that? We're exposing subendothelial collagen, right? Good. What would that do? What components would that activate? Coagulation factor or platelet? If subendothelial collagen is linked to what? Platelet or coagulation factor?
Platelet.
Platelet. So that's why the predominant clots that will be found in arterial thrombus, right, will be platelet thrombus. Yes. Once we damage the endothelial cells, once endothelial injuries, so we have exposed subendothelial collagen. And remember, this is directly linked to platelet, not coagulation factors. Yeah, and even some of those things that the endothelial cells will release, thromboxane A2, the vasoconstrictors, they are going to slow down blood flow, activate platelets as well, and typically, right, they primarily form, right, they lead to platelet thrombus. So the thrombus that will be you're gonna see here, the kind of clots, predominantly will be made up of platelet. Platelet. This will be a predominant platelet thrombus. While in the venous end, right, when there's stasis of blood is not flowing properly in the veins. So patient just travel, long flights, all these kind of things, bedridden, post-surgical patients, fracture patients, right? There's venous stasis, but it's not flowing properly. And they also have maybe hypercoagulable state. There's 83 deficiency, maybe from nephrotic syndrome. There's no protein CNS. Patient has a factor 5 Leiden mutation, right? That leads to resistance to CNS. Patient has some other sort of hypercoagulative state, right? Yeah, in the body. And what happens is that this will actually activate coagulation factors, coagulation cascade factors. So the clot that will be formed in the venous end will be what? Will be fibrin thrombus. Fibrin. You know, see a ball of fibrin, red blood cell. Maybe platelets will be there, but they are not activated. They're going to be attached to fibrin and fibrinogen and form like a ball of clot in the blood vessel, but it's primarily fibrin that will be there. Any red blood cell you see there, red blood cell, platelet, that they're just attached to it, but they're not really activated. They're attached and they form the predominantly right a fibrin clot in the venous system. But in the arterial system, it's going to be platelet thrombus. So based on these pathogenesis, if a patient has a disease, right, due to so let's talk about conditions that can result from the arterial thrombus. In the arteries, complications or let's say consequences of having a platelet thrombus in the arteries will be definitely ischemia, right? Ischemia, organ ischemia. We're looking at what's the name? Ischemia, acute or chronic. Examples: maybe cerebral vessel stroke. In the heart, we're looking at MI, angina, peripheral artery or ischemia, mesenteric ischemia, right? These are going to be examples of consequences of arterial thrombus, right, or platelet clot formation, ischemia, stroke, MI, things like that. Yeah. In the On the venous side, consequences will be what, right? DVT, deep vein thrombosis, venous thrombosis, right, and things like pulmonary embolism. Yeah, it can also lead to maybe stroke in a patient with what, with VSD, ASD, right? Yeah, right. DVT might lead to stroke. So, but it's DVT that travels right to the right heart and then cross to the left side and goes systemically. Yeah, so you're gonna see that. Another scenario, oh yes, another scenario where you might see fibrin clot will be what? Will be AFib. Yes, the clot in AFib, right? The cardiogenic thrombus. The thrombus that is formed in the heart. In AFib or SVTs like AFib, A flutter, right? Or in patient with CHF, congenital heart failure, or patient with ventricular aneurysm, as well as the clots that will be formed, right, in triple A, abdominal aortic aneurysm. Because remember, if there's aneurysm, there will be stasis. All those things are fibrin clot because it's stasis of blood that is pathogenesis, not endothelial injury. Right. Stasis, not endothelial injury. The atrium is not contracting very, very well. Blood is going to be in stasis in the atrium. So, fibrin clot. Patient has CHF. The heart is dilated, aneurysm of the ventricle. There will be stasis of blood, fibrin. Patient has triple A, abdominal aortic aneurysm, right? Clot can form in the aneurysm because of stasis, not primarily because of endothelial injury in that case, right? Likely stasis. So all these clots are going to be mostly fibrin clot as well, not platelets, because it's not due to endothelial injury primarily, they are due to stasis of blood. Yeah, in those locations. Yeah. So, which brings us to how do we treat? So my
Before you move on, what's the condition you have after cardiogenic thrombus? You have cardiogenic thrombus in something.
SVT, supraventricular
SVT.
tachycardia, like AFib.
Thank you.
Yeah. So which brings me down to treatment. How will I treat these conditions? So for arterial thrombus, it's going to be what, antiplatelet, right? That I'm going to use because those are primarily platelet thrombus, with or without anticoagulants. But primarily you're using antiplatelets for these, and then for venous thrombus, we're going to be using anticoagulants. For treatment, anticoagulant without antiplatelets, which makes sense because fibrin is linked to platelets, but platelets are not like, they don't really play a major role in coagulation cascade, right? Maybe activation and stuff. So if a patient has a venous thrombus, anticoagulants would be the only thing you're giving them. Antiplatelets would be completely useless in those patients. But if a patient has a platelet thrombus, right, because platelet aggregation is mediated by fibrinogen, so you can definitely, you're primarily giving antiplatelets, aspirin, clopidogrel, etc. Sometimes you might also add heparin, to acutely, right? But for chronic management, typically antiplatelets. Yeah. So this is how we choose. Depending on what the clot is or what the mechanism is, that will decide what kind of blood thinner, right, I'm gonna use in that patient to treat them. So this is how we choose, which makes sense. Questions?
Just to clarify, you're saying that for the treatment of the platelet-based clots, we use both antiplatelets and anticoagulants.
Primarily antiplatelets.
Yeah. And secondary
Sometimes,
anticoagulants.
sometimes there are scenarios where you can add anticoagulants, right? Yeah, especially in acute settings.
Okay, thank you.
Acute settings. In for venous thrombosis, usually just anticoagulants. Antiplatelets play no role in venous thrombosis at all. Yeah, so anticoagulants only. When do you use TPA? So TPA is going to be used in an emergency situation, right? In both, right? Because TPA can be used in either one. Actually, in both cases, TPA can break down. It can break down fibrin and break down platelet clot because fibrin platelet aggregation, right? It can also break down fibrin clot as well pretty quickly. So TPA is going to be indicated in. It can be used in both cases in emergency. So if a patient has, we're dealing with ACS, acute coronary syndrome, right? That's an emergency. The whole coronary artery is clogged acutely. Patient has ischemic stroke, and they're still within the window, right? Within the window for TPA, right? You can give TPA to quickly break down the platelet clot. Also, if you have like DVT that is so large and patient is unstable, or they have a PE that is so large they are in shock, right? You can also use what? Right? You can use TPA to quickly break down the clot. So we really use that in unstable patient. Sorry, patient with arterial thrombus if they're still within the window, within thrombolytic window, which is typically around I think 4 hours for stroke, ischemic stroke, and it can be up to I think maybe 12 hours for ACS. Yeah. So they're still within that window where thrombolytics will not be harmful, right? 4 hours for ischemic stroke, within like 4 hours of the stroke for ischemic stroke, within like 12 hours for ACS, MI, and things. But for when they're used for venous thrombosis, in patient with like PE with shock, obstructive shock, so they have a large clot. I want to quickly break down the clot if there's no contraindication, right? Or patient with DVT with severe swelling of the leg as well as maybe ischemia of the leg, right? So I want to quickly break down the clot, TPA. Yeah, so you can use that in an emergency situation. Patient is very, very unstable, but they come in with arterial thrombus and they come in early with arterial thrombus. I will have no other choice to break down the clot. You can use TPA if there's no contraindication. If it's venous thrombus, if it's a very, very large clot in the veins, like pulmonary embolism, and they're in shock or DVT that leads to severe leg ischemia, you break it down, right, with TPA. Yeah. All right. Questions? Okay. Let's do questions on this. Let's do some questions on what we just did today. Let's try and apply that to questions and see the trends. Um.
Well, quickly before you go on, let me just say the end of the venous emergency for TPA.
Oh, okay. Go ahead.
Severe,
So severe swelling, right, or ischemia. Severe swelling or ischemia, right?
thank you.
Okay. Shani, can we use your U word, please? I think we can narrow down the question on U word better.
Yes, sir.
Right, thank you. Here's your U-word. And for the hematology, let's see if we can just select coagulation, right? Systems and disorders. Send this. I'll send you guys this notes though. Let's see. I think some of the writings are legible, right? By and large.
What objection I select everything.